All righty. Thank you again for being here this evening. If we could start off with some general introductions about, who you are, your credentials, and the populations that you serve. That would be a great place to start. I'm just going to kind of go from the direction of which I see you on my screen. So Shannon, if you'd be willing to start us off this evening.
Sure. So hi, I'm Shannon Smythe. I was one of the original New Chi Upsilon founding members, so it's great to see you guys continuing this, I guess, legacy on. It's only been a few years, but it's really awesome. And I'm really happy to see the chapter being active. So I work at the VA in Eugene. I think I'm one of probably about 2 people that are professional counselors that work for VA hospitals in Oregon. I'm an LPC. I got most of my clinical hours done at the Mission, Eugene Mission. That's where I learned a lot about homelessness and homeless veterans. And my position right now with the VA is working with their permanent housing program, which is HUD-VASH. On top of getting the LPC, I think I'm one of 18 certified clinical mental health counselors in Oregon as well. So.
Fantastic. Thank you so much for being with us this evening, Shannon.
Thanks.
Kendra.
Sorry, I was taking notes. So my name is Kendra Pennington. I am an MSW. I graduated from Pacific University here in Eugene. So right down the way from you all, small little campus. So right out during my MSW program, I worked for a United States Senator. And so my background is in Medicare, Medicaid, Social Security, all of that jazz, and then some. And then I came to senior in disability services here in February, the beginning of the pandemic. So it has been quite fun. So all I know how to do is operate in crisis mode. So I am excited to be here and excited to field some questions and hear from the other panelists as well. So thank you so much once again for including us and inviting us.
Thank you again for being here. It's greatly appreciated, and way to have a trial by fire. That sounds intense. Goodness. All right. Pam.
So my name is Pam Lehrman. I am an LPC intern. This is like my 3rd career. Penn State University is where I got my master's degree in 2017. So I've just finished my 3rd year at Willamette Family. That's a women's residential. And I also run a group. So I do individual therapy with my clients, and I run a group, vocational readiness, and bring in speakers, including vocational rehabilitation under DHS. Because, a lot of our clients need employment support. And so I'm really, I've been enjoying doing that. It is difficult work. The pandemic has affected us, of course. And so I know that some of your questions are around that. I am in the residence, and I am doing telehealth. So Oregon girl, right? I was in Pennsylvania for 15 years and got an opportunity. Penn State has the 6th ranked program in the nation. And I really feel that, starting my career at age 50 was right on time. So, yeah.
Happen when they're supposed to happen.
Mm-hmm.
Well, yeah. Welcome back. And I'm, again, really grateful for you and for all 3 of you to be here this evening. The amount of knowledge that has figuratively walked through these doors is quite impressive. So, well, let's kind of dive right on in. The pandemic is first and foremost in, everybody's mind. I do not believe there's anyone who has not been affected in some way. Now, we, as either students in the program, working to become LPCs, or fresh graduates who are actually nobody right now, because until we get our registered internship, we don't exist, I'm pretty sure. We want to know what is going on and what we can do to make a difference when we actually get out there. What do we need to know? So this, I'm looking at the questions we've typed up, and this is on there. It's just going to phrase it a little bit differently, but basically, what what aspects of the pandemic have been the most difficult for the population with whom you work, right? And I will start, kind of go through our cycle here. So Shannon, would you be willing to field that one first?
Sure. So I was just thinking about what Kendra said about working for the senator, and I got excited because I started out at congressional offices too. Took me down memory lane. So, but back to your question. So the population that I work with is, a specific culture, and that's veterans culture. And then the subpopulation is homeless veterans. So in order to be eligible for the program I work with, one has to be experiencing homelessness. So, and it's can be quite a bit different than kind of the normal mainstream veterans culture with combat deployments and all that. So just to preface that, I'm already working with people with a lot of adverse childhood experiences and trauma before they enter the military, then mixed with sometimes trauma in the military, not always. It can present manifest complex trauma. So when we get people, that's oftentimes how they present with this kind of complex trauma, which is very different than what the movies might present, where all military people go to war and they've seen some stuff and that's like their main stressor in life. But a little bit different. So with the folks I work with, they might already be experiencing a lot of isolation, not only from their veteran peers, but just through their community in general. So throwing COVID on top of that, and then shutting down a lot of community services that normally would be available and open for walk-in. That's something I've seen be a pretty big stressor. I just have an example of the VA closing most of its non-emergent medical and mental health services. Has been something I've seen. One example of that is dental services. So a lot of the veterans experiencing homelessness that I work with, that's like an extremely necessary medical item is teeth and dental care. And I've seen a lot of veterans go through a lot of pain and anguish from not getting that through the pandemic. And of course that can affect mental health and medical health in various ways. One of the ways that we've kind of combated the isolation, normally with our housing program, we're doing home visits. So we're going out to the veterans' homes and seeing it. And it's not really an inspection as much as a check-in, just to be physically present. And COVID has actually really limited that. In fact, I'm grounded to my office right now. I'm not allowed to leave due to the policies. So how do we make that connection with veterans that are in their homes and may not have a whole lot of socialization? One thing that I'm sure is popular in other agencies and offices is the telehealth, telemental health services. The VA is really pushing that now with software called video voice conference, and it's much like Zoom, but it's a secure method to reach veterans. And one might think, okay, well, how do you reach veterans through secure telecommunication if you're dealing with a homeless population? We recently received a program called the Digital Divide Program. And it's much like the National Lifeline Program, free phone. Heard it maybe working around in agencies or Obama phone or whatever, but this is specifically for veterans. So I've kind of championed this in my office to breach that digital divide and provide these devices to the veterans in their homes so we can have some kind of face-to-face contact.
Excellent. Wow, thank you. Kendra, so in the population with whom you are working, what would you say are the most challenging aspects of this pandemic?
Yeah, so I am a community program analyst. So I deal at the kind of, you got the macro, the meso, and then the micro. Did I already say micro? Macro, whatever. So I'm more dealing with the meso kind of things. I do not have direct client contact. So what I am dealing with is, trying to get money and manage programs that help all of these folks, our senior and disability services. So here are some of the major things that we have seen from that meso level, and Shannon already kind of spoke to a lot of these. Mental health with our seniors and people who are experiencing disabilities, the isolation and the loneliness that they have been experiencing, because our congregate dining, which is our Cafe 60. So all the folks who come together to socialize and hang out and see each other every single day, that hasn't happened since March 18th, I believe. So folks are getting their meals to go. And that is also modified as well because, people have to stay 6 feet apart. Only a certain amount of people can be in the building at once. So there isn't any socializing going on. Folks are just coming in, picking up their meals, and then taking them back home to eat them in their residence. People who experience disabilities are 5 times more likely to have mental health concerns than folks without disabilities. And a lot of the times, what we're dealing with isn't just, it's just a senior, right? It's a senior who experiences a disability, who also is having some mental health issues, who also has transportation issues, right? We're not just dealing with one isolated issue. It's always compound with most folks. So, and then Shannon, like you already spoke to as well, your VA office is closed down, and our office didn't close down. Our main office in Eugene, we modified the hours of our office. So the hours are 10 a.m. to 2 p.m. But once again, seniors are used to that face-to-face interaction. They don't necessarily do the email. They don't want to FaceTime. They want to come in and have that person-to-person interaction. So it was increasingly difficult to get folks to call. And then there was a bunch of scams going on with COVID as well. So that compounded people not wanting to call us back or their case managers, because there was a lot of scams going around as well. So we modified our services, and like Shannon already spoke to, our staff, most of our staff are not doing the in-home visits. They are modified, and most of the time, the only folks that are gonna go in a home are gonna be our adult protective services workers, so our APS units, because most of the time there's safety concerns around those issues, so they have to physically go in the home. And then technology gaps. We've seen a huge barrier in technology because folks don't know how to use a tablet, a phone, a laptop, or they don't have them. We've seen both of those issues. So our ADRC, which is our Aging and Disability Resource Center, got a grant to help people get laptops, to help them at least do a little telehealth, a little Skype, to be more connected in the community, because as we all know, a lot of people aren't meeting in person, and if they are meeting in person, it's limited, and you have to wear masks and you have to social distance, and that can be a lot for our population. So that's been a huge barrier. And then transportation as well. We partner with tribal, our older Native Americans and the tribes. So the elders, when basically all of the transportation shut down, had to rely on taxi services. And as we all know, taxi services are very expensive, especially if you're going to and from destinations as well. So that became very, very expensive. And then, as I kind of spoke to, a lot of folks were worrisome and hesitant around food security as well, because everyone rushed to the grocery store. We all were kind of guilty of it, right? We all wanted those resources, and it left our seniors and people with disabilities who couldn't access transportation to go to the grocery stores to get those needed items. So we had to be creative around that with our community partners to try to get folks the resources they needed. And then our respite as well, so our respite is basically giving our caregivers a temporary break from who they're giving care for. And during COVID, people aren't going in other people's homes. It's super limited. So parents, grandparents who are taking care of their children are not getting breaks. You're home with them 24/7, also trying to homeschool them. So that was a lot for them to handle too. So we tried to give them some financial relief through a grant through United Way that we were able to secure. So, and then we partner with Oregon Law Center for our senior law services. So we saw a huge increase in people wanting resources for wills and people having issues with housing. So those also increased really, really significantly. And kind of, once again, all of these issues existed pre-COVID, but COVID extremely amplified all these barriers and gaps that these populations have been experiencing. So thank you. I know that was a lot. I'm sorry.
It is, and at the same time, I'm not surprised. And as you pointed out, there's some similarities between Shannon's population and with the population that you're overseeing in terms of the isolation and the loneliness and the lack of access to resources. I'm thinking Maslow's hierarchy, right? The basic needs, and then you've got love and belonging. And this pandemic has taken out both of them for both of these populations.
Yeah. And, with Shannon too, I'm sure that we serve, the same, if not similar, consumers as well, because consumers are, clients are all over the place and trying to get as many services as they can. So, it's intersectional, not one agency is doing it all by themselves. We are all doing it together. So.
Indeed. Coming together yet. Thank you very much, Kendra. So Pam, it sounds like you've been able to be both, be able to maintain some of the in-person, in-residence activities. And I imagine this could be a little different. At the same time, I know that this pandemic has also greatly affected the population with whom you work. So what would you say are the challenges, the most difficult aspect of this pandemic for your field?
So I'll touch on that. I'm also interested in hearing from you all about what your interests are a little bit, and if you have questions, just interrupt. So I came on as an outpatient and residential therapist. So I still have several clients who have been with me for 2 to 3 years. And then primarily I am a residential therapist. So for the outpatients, I will say, obviously the pandemic has affected their connectivity, all of those things. I have a client that is trying to be also a teacher, right? How do I homeschool my daughter? How do I know what I'm doing is good? Is it enough? All of these factors come. And those clients who are endeavoring to recover, have lost in-person meetings and the importance of those kinds of, we would call them protective factors, right, against relapse. So that is, of course, you're going to see increasing anxiety and depression. I mean, that's really the things that are coming up. They're coming up for those of us that don't tend to have anxiety and depression, right? So, I mean, that's just sort of part and parcel. For residential clients, I think the biggest barrier is we bring them in and we put them in observation, which is a reframe of the word quarantine, because we need to keep the community safe. So imagine yourself going into a 8-9 day solitary experience, largely difficult just in general. And then if you're coming off of substances and you may have experienced recent and chronic trauma, not easy. So sometimes we lose, quote unquote, clients in that initial window if they're struggling. Mental health concerns, we are getting better. You know, we have a nurse practitioner. You know, Willamette Family does really try to support the clients where they are and as they come in. And sometimes, is this a substance use concern, or is this a mental health? As you know, often those are co-occurring. So that's probably the biggest barrier. The substance abuse counselors run groups. They have now started bringing those observation clients into group via Zoom, which does help, right? So the company has learned, hey, we need to accommodate the pandemic. So everyone is masked, staff and clients. Everyone, as you all likely feel at some level, right, is over it. And yet it's super important. Staff have additional responsibilities because we, you know, could bring things in. And so nobody is monitoring your day to day, but I feel a certain level of responsibility to not do certain things. And, you know, certainly we're all looking at what Kate Brown is saying and trying to follow those guidelines, practice what we preach. So beyond that, some of the women in residential have children. Some of them are with them in residential, and some of them are staying with family, or they may have a DHS case and they're with a safety service provider. They are not seeing their kids in person. So that is a huge barrier for them that will keep some people from coming into treatment. And yet it's really important. That's a DHS guideline right now as well. It's not that, you know, a treatment agency is saying, no, we're not going to support that. It's, you know, that is part of what we're dealing with in Lane County. So those, I think, you know, not being able to have family sessions and those kinds of things certainly are factors for them. And so I think that's that's more than I intended to say, but I think I'm covering sort of the other things. Obviously, when we talk about wellness, we are not able to transport to the gym on a weekly basis. And so as the weather turns, clients don't get to do walks, or we do have a small group that will run. You know, it affects our mental health as well. So, you know, just a lot of additional layers, as you all have mentioned, you know, before.
Wow. Well, thank you for speaking to that. It's, you know, it's one thing to imagine that it must be happening, and it's another to kind of get that confirmation that, yeah, this is the reality of what having to operate in a pandemic and what it looks like and what that means. So Pam, you had asked kind of what, you know, we wanted to get out of this conversation. Maybe you're muted.
Right. I think it's helpful, not to speak for Kendra and Shannon, but right, like who's our audience? We could speak more or less specifically to that. Do you know who your quote preferred population is? At this point, sometimes we get asked that and we don't, and we're like, I don't know, so it's just, kind of an interest, just to get a sense of who you all are, who's your cohort.
It's a really good question. And the answer is yes. Between those of us who are here today, I mean, we all have, of the 5 of us here who are students or recently ex-students, we have varying preferred populations. But I do know that of the audience that will watch this, the chances of being in a kind of a broader population, because I think most folks are going into their internship. So they're either looking for their internship or they are just barely going to be starting it. We will be bringing in the newest cohort who just finished up their first semester. And so a lot of them will have access to this as well. And so kind of this information may actually help them determine what population they might want to work with. So with that kind of guidance, we're primarily interested in, kind of getting this background information of what have y'all seen? What are you seeing that's working? What are you seeing that's not working? What are the gaps? What recommendations would you make that, a student or someone who is wanting to enter into this field, how could we benefit by what y'all have learned the hard way? So if we take it back around to Shannon.
All right, thanks, Marcy. So,
Thank you.
Yeah. So, one of the questions was, what are some of the most frequently identified challenges for population I work with? And going back to military and veterans culture and cultural competency, probably one of the most flashy hot button issues within veterans culture is the 22 suicides a day. I don't know if everybody's heard about that, but you'll see it on bumper stickers, you'll see it on commercials, all that. It's very flashy, but this is kind of a soapbox issue for me. But a couple of theories, including suicide postvention. That's after an individual has died by suicide. It's the steps that you take after that is to not focus on the actual death and the action of suicide. I'll give an example. There's 22,000 nonprofits in the United States that say that they help veterans, and many of them within their names have like beat the 22 or stomp out the 22 and all that. And they do things like do 22 push-ups to like recognize how many veterans died a day. Well, the theories like suicide postvention say don't focus on that. Don't focus on the death. Focus on working through the issue with people. For example, don't do the 22 push-ups a day. Focus on how many lives were saved from the Veterans Crisis Line or the National Hotline. That's what they're saying will actually help. So if you really want to help with the suicide, recognizing it for sure, that's needed. But along the way, there are things that we can do. So I'll give an example of what I do. I'm the chapter captain of Team Red, White, and Blue, which is one of the 22,000 nonprofits in the United States that say that they help veterans. But what Team Red, White, and Blue has done nationally is done a study on veterans wellness. And they've focused on 3 particular domains. The first one's physical activity. The second one is socialization. And the third one is community service or connectivity to one's community. And with our other speakers today, we've kind of seen that thread go through the physical activity, especially within the elderly population. That's extremely important. The socialization with one's peers and then the connectivity to the community have all been extremely affected by the pandemic. So that's some of the main factors within all veterans I've seen that this kind of being a big challenge are those three areas.
Thank you very much. This is the boots on the ground idea. I really appreciate it. And even if you are at the meso level, Kendra, like you speak of, that ability to kind of sit back and be objective and notice like the trends that you are seeing. And I feel like you might actually be even in a very good position to speak to what is working, what isn't working, and what these gaps might be.
Yeah, so once again, spitballing off Shannon, you just tee me right up, so I appreciate that. So kind of the services that we have lost at senior and disability service due to COVID has been our Living Well with Chronic Conditions program. And this program focused on folks that have, diabetes, that need to eat healthier, that need to manage these chronic conditions. And because that one of the main provisions of the workshop is that we meet in person, that these workshops occur in person, well, that couldn't happen. So in March of 2020, we shut down that program because like I said, one of the main things is that we have to meet in person for that funding. It's pretty specific. So as of right now, that program's not operating. And as Shannon spoke to, like, that is key, right? You need to be around people who are experiencing the same experiences you are to get that lift, to be a part of that community, and get that socialization as well. So that program has been severely impacted by COVID. And then our PEARLS program, which is our mental health for our senior population. The state of Oregon decided that in August of 2020 that they were going to defund that. So right now, as of September of 2020, we wrapped up all of our clients that were on that service because that funding went away. So right now that program isn't operational as well. And then we've had a huge, we got really lucky when the pandemic hit. We had a huge influx of volunteers from the community who wanted to participate in our Meals on Wheels program to make sure that seniors had and still have access to nutritious foods. So a lot of other triple A's is what they call them, areas on aging in Oregon weren't able to keep up with their volunteers. Lane County has, and we still continue to do that. We are starting to see some volunteers trickle off, which has started to affect our ability to run that program and get meals out to folks. But we have staff who are stepping up to deliver those meals. So once again, it's that program is still happening. It's still occurring. We still have volunteers, but we're always looking for more volunteers. So that's always the ebb and flow of that program. But because of COVID, we are spending a lot of time making sure that folks are fed. And then we have our senior companion program that also just completely stopped running because our senior companion program is a collaboration with Lane Community College. And what they do is they get senior volunteers matched up with one of our senior clients, and they go do errands, they go on walks, they kind of socialize, do puzzles, a plethora of things. And once again, that has completely stopped. But luckily the senior companion program has been nice enough to pick up the phone and call clients, just to check in every once in a while, just to make sure that they're doing okay, if they need anything, if we can help them with anything. So those are kind of the major programs that we have that have been severely impacted due to COVID.
So these again, it kind of comes down to the basic needs. And it's, as you said, Shannon, that the connectivity, that socialization aspect that directly combats the isolation that this pandemic has brought. Okay. We're going to circle back around to that. But first, so Pam, how about from your perspective, what have you, because you literally are, again, I love this boots on the ground phrase. You're probably going to hear it a lot today. Please bear with me. You're in it. You literally are working with these women in treatment, and you have a really good view of what's working and maybe what isn't.
I do think that we've touched on it in different ways, and it is that the loss of services that are non-emergent is increasing. And regardless of what our politics are, right, 2021 does hold some hope. So what I wrote is, I think we need to go back to grassroots, right? And coordination of care, interagencies. We already have some of that, but I think we're going to need to do better at that. Warm handoffs where there's, call it case management, but where there's a connection to a person, right? And we all know that that can often be the difference. And then I'm thinking about my own agency. We should be streamlining and strengthening the programs that are really effective. What can we maybe not be doing? We're all trying to accommodate this, and normal, don't we all love that word? I don't know where you guys are in your curriculum, but if you've taken diagnosis, right, and we all know about bias in the DSM and what is normal, right? We are never going to see normal again, such as it was. And so we need to wrap our minds around that it's unlikely that teletherapy is going to go away, nor should it, right? That said, I always vote for in-person because, there's evidence about the benefit there. There's also evidence that if I can see you and you can see me, that's better than a phone call.
Yeah.
So technology, again, what are we going to do in Lane County to boost the health and wellness of our citizens?
Absolutely. I had just seen an email, or I think it might have been a post, but saying that like a whole handful of insurances, like the legislation went through to where they are going to be approving telehealth through at least June of 2021. But it does seem like this is the area where actually stepping into the advocacy role and working for legislation to get the funding to programs, kind of like the program, Kendra, that got cut because it has to be in person. Well, hoity-toity there. What if it can't be? Kind of thinking outside the box and being able to get the technology in people's hands, being able to get it covered by insurance if insurance is an option, whether that is just Medicaid, Medicare, or one of the however many are out there. Wow. Okay, so to go for a little bit more intervention specific questions, Pam, I'm going to stay with you for a moment. Have you seen have you changed your interventions that you see that you're using in sessions? Are people responding differently? Has there been any shift in terms of what's actually working with clients right now?
Well, yes. One gets creative if we're doing telehealth, right? In March, I set up a home office self-taught taught myself Zoom and figured it out, right? Learned how to share my screen, right? Yeah. Today in clinical supervision, we figured out I can not only share my screen, but I can share a video that the individual can actually hear. And I do use music, meditation, empowerment videos. Happens to be a 68-second empowerment clip that goes along with something I like to explore with clients. And so there's a loss there because we don't get to do that in person. And yet with a little thinking and planning and, figuring it out, we can provide some of those services. I will say my biggest impact as an educator, I run vocational readiness, and I'm not able to bring in my presenters right now, which is really a loss for the group. The group still is able to meet because they are all in residence. So, they're not leaving. And we have there are protocols if clients do have to leave the building for whatever, like there are some pretty strict guidelines. Everyone's temperature is taken, and, like we're following all the things that you go to the doctor, right? They ask you the questions and all that. So, as I look at starting a new group in January, I'm going to have to really get creative and maybe talk with my presenters about how can we still keep that effectiveness. If I have one of the directors from vocational rehabilitation, right, it used to be Tessa Siebert, and she would come in, give her thing, spend 60, 75 minutes with the women. So there's a shift if we bring her in via Zoom. So, some of these things, as therapists, right, we need to learn how to find the ability to reframe that, right? Flip that glass over and find the strength in that. So that's, I'd say for me, can it be frustrating? Sure. Can you find a workaround? Sure. And clients that haven't experienced a group like that won't know the difference, right? We know the difference. So, yeah.
True. You bring in a kind of a good aspect. It's what you, the facilitator, brings to it. This is their experience.
And it doesn't help us to apologize for what we're not delivering, right? We just deliver the best that we can.
Absolutely. Absolutely. Wow. Shannon, have you had to change, or let me rephrase that. How have you had to change how you interact with your clients?
Sure. So just going back to the video voice conference, which is just the software, the proprietary software that the VA is using right now. That's probably the biggest push from VA central office in Washington, D.C. now. And really, really highly encouraged from everybody from substance use disorder providers to mental health, psychiatry, all that. Some of the things I've seen with telemedicine and telemental health was around the start of the pandemic. They came up with basically a HIPAA waiver for a lot of different platforms for using telemental health. So, for example, I think we're allowed to use Facebook Messenger to provide psychotherapy, which, all of you past ethics, the kind of challenges with that. But there, in any case, I've seen a lot of different exceptions to HIPAA, and we've had to be very creative to reach clients, not only just through doing our appointments through telemental health, but Pam and Kendra, I'm sure we all work with forms and documentation, and like, how do we get that done? How do we get it done electronically? There's just a lot of things that happen every day that kind of during non-pandemic we might take for granted, but So so I've seen some creative ways to get around that. I'm probably not going to use Facebook Messenger, but there's a lot of other platforms out there that are a little bit better. Um, uh, and just a thought that I had is when we go back to kind of pre-pandemic policy and HIPAA, under normal circumstances, the privacy needs, the encryption, the methods that we contact our clients, is a lot more strict under those policies and laws. So how do we go, how do we go from kind of COVID culture right now where we're able to do all this creative stuff to back to to normal, and which is very rigid. And so one of the things that I've done personally is I did the Center for Credentialing and Education that does the approved clinical supervisor and a couple other credentials that y'all might have seen around. They do one called the Board Certified Telemental Health Provider credential. And it used to be called Distant Certified Counselor, DCC. So now it's BCTMH, but I'll just kind of plug that in. There's a lot of different courses one can take on telemental health and all that, but this seems to be the most comprehensive I've seen their approved listings. And then you test out of it and you can be board certified, which I might recommend if one is thinking about doing telemental health in the future, or especially if they're thinking about doing that primarily, which a lot of people might. I don't really see this telemental health thing going away anytime soon, because we're like hyper utilizing it right now. So once things go back to quote unquote normal, I think we're going to take a lot of what we've learned and keep doing it. And that may mean like a lot of in-person offices closing depending on the agency and the funding. And we've seen a lot of that recently. Like why have a brick and mortar office if we're not using it all? So just some things to think about, and some training and credentialing to consider.
Excellent, thank you. Well, you bring up, as you said, Kendra, building off of what Shannon says, you do bring up an interesting point. This shift into, I really like that, this COVID culture. It is showing us that we really can do a lot that we didn't think we could. And now that we can do it, what's the point? Why should we pay for these extra services? People are doing fine. Which would no, they're not. So as people, so we are working toward kind of developing our specific populations. We are working toward wanting to go into the field to help. Most all of us, well, for practicum purposes, we all start off in the Bushnell clinic, right? So where it's the student population plus whichever community members come seek us out. And I know from personal experience, that really kind of does run the gamut in terms of age or ability. But it's still a very thin slice of the possible clientele that's out there. So how can we do best for our profession as well as the clients? Okay. Kendra, from your perspective, kind of as you've been overseeing, senior and disabled services, what aspects kind of as a, I don't want to say general clinician, but again, that's kind of where we are. This is the populations we're working with. Do you see things that maybe we should be watching for possibly in our clientele that would indicate like we should connect them to someone like you, or like what signs are there that we need to be aware of?
Yeah, so that's an excellent question. And I would always err on the side of pointing folks our way regardless. And then having our staff make those determinations based upon, there's a gamut of assessments. I'm sure Shannon and Pam can both speak to that. And like I said, I'm not that boots on the ground like you spoke to as well, Marcy. So I am not an expert at everything, but there are staff members who
I'm surprised.
I know, right? But we have the staff who are experts in their particular field and know their programs like no one else I've ever known, and it's amazing. So I would always err on the side of if someone's 60 or older or experiences a disability, point them in our direction, and we can get them through assessments. We can get them hooked up. We collaborate with a lot of agencies in the community as well, and we try to do that warm handoff as much as we can, because like I said, no one agency is in this by themselves, and it takes us all to help out each other, especially now more than ever, even with the wildfires too. I don't know if Shannon and Pam had a lot to do during the wildfires, but we sure did. And once again, that took a community, and it's still taking a community to help build back up that community. And once again, when the community rallied around those folks that were impacted by those wildfires, people pointed them in our direction, and then we pointed them in another agency direction, and that agency pointed them in another direction, So I always err on the side of pointing people to the resources that are available in their community, and having that agency kind of hold their hand through that process and be that that person-centered collaboration that needs to occur to get them every single resource that our community has available. So I hope that answered your question.
That did. Is there a number that we would call, or how would we actually go about doing that?
Yeah, so I can give you our Aging and Disability Resource Center. And this is kind of our OAA program, so our Older American Act programs. So these are programs that aren't connected to Medicaid or Medicare funding. That's a completely different pool of money. And I personally, at this agency, don't deal with that side. I deal with the discretionary funds and these Older American Act programs that I've been speaking to. So like our Meals on Wheels, our Senior Companion, our Caregiver Respite, all that stuff comes out of a different pool of money than the Medicare and Medicaid stuff. So I'll put it in the chat. I'll put our ADRC number in the chat for everybody.
Perfect, because these are, if it's okay, I would love to put these resources up in the Bushnell clinic, like in the student break room, if you will, because not only, as Tiffany just typed in, but I know a number of students that would really like to move into that advocacy volunteering role, be more plugged in, but to be able to have these resources to connect our clients with, because it is amazing who ends up seeking help at the Bushnell Clinic because it is low cost / free. I mean, I actually haven't charged anybody any money ever in that program, because I'm like, hey, I can waive this. Do you need a waiver? Say yes.
That's so great. I'll put the number in there too. And we also have a gamut of flyers too. If you all want some flyers, we can walk them on down to the university. So I did put my email in the chat, but I'll also put that ADRC number as well. So
perfect. Kendra, thank you. Pam, so substance use in a pandemic, we do we go through alcohol and drug, an addictions class, so to speak, and it basically says, hey, you should assess for this. And then they set us free to go work on people. Do you have any suggestions or any things that you might suggest that we look at or kind of keep an ear out that you might have noticed is coming up more these days than maybe was pre-pandemic?
I think everyone that you will engage with there ought to be some conversation around how comfortable they are with their use, right? That's not always the first question, but you know, that's ideally, you know, that kind of honest rapport building, right? If your client is concerned, can you be that safe place for them to talk about that and to use motivational interviewing to see, you know, do they feel like they need to be looking at that? And sometimes if they're just talking, right, and you hear party or missing work, or, you know, just those little signs and symptoms. Yes, the DSM tells us, you know, criteria. Interestingly, from the 4 to the 5, we dropped that DUI is a sign or symptom, right? Well, it's really easy to not qualify for criteria, but yet have a substance use disorder, right? So I think we culturally would do better talking to our clients earlier without judgment, so that people who have a concern look at it earlier so that it doesn't get to a progressive space where it's difficult for them to make a change. So, you know, there is brain science around the progression. I personally believe in harm reduction. Not everyone can monitor or modify. Some people need to be abstinent. And so working for a treatment house currently, right? I don't use a megaphone to talk about harm reduction, right? However, that is the reality of for most people. So it's, you know, where can we find a place that we have relative happiness in our life, right? Where those things aren't controlling and impacting our employment or relationships, those, you know, legal, those are kind of the big 3. So yeah. And so depending on who's doing the assessments and how conversational that is, you know, hey, would you like to talk about that at some point, right? And, you know, you start to read your client. I think nationally, if you're reading anything, right, we have seen substance use, domestic violence are both up, right? The isolation that the pandemic has happened, you know, is unfortunate.
Indeed. Well, Laura just typed in a fantastic question. I think she's reading my mind, because we have done a lot of talking about the client population, but you 3 represent a slice of our potential client population also, right? And it also really asks to, you are in 3 very stressful positions right now. How are each of you taking care of yourselves right now? You know, Pam, how are you doing your self-care? What does your self-care look like these days?
Sometimes self-care means I'm not doing anything.
I like it.
Because, you know, in a pandemic, it's amazing to feel overprogrammed and really busy with very little downtime. And yet, so sometimes that's binge watching, you know, The Crown or The Queen's Gambit, you know, those kinds of things, bubble baths, right? Exercise, a lot of music. I do write a little bit. And so, you know, I've learned to be a little bit kinder to myself about what I expect, and that self-care can look different every day. But to try to make sure I'm doing at least something, you know, for self. And, you know, that's okay, right? Because being hard on ourselves isn't really good self-care. Yeah.
Indeed, leaning into that compassion.
Yeah.
Excellent. Shannon, how about for you?
So I don't know if this is much self-care, but self-preservation. But I'm one of the only folks that are working at our clinic right now. Pretty much everyone else has been sent home to telework. But I just have to be especially mindful when I'm at work, of all the safety needs. So I don't know if everybody's following CDC recommendations, but when working in medical clinics, they're saying not only just a mask, but you need an N95 respirator. Goggles are recommended for spray, face shield on top of that. So I just kind of joke around, but when someone comes into the clinic asking for help and is in a crisis, like, and I show up like, in a full suit, I wonder what impact that, that's having initially. But at the same time, like, in order to help people, I have to stay healthy and just not get sick. So that's probably where a lot of my energy is going in right now, especially working with folks who are not able to isolate in the homeless population just because of their circumstances. So doing that, and of course just taking the time for myself to make sure I get into the office with a clear head, like Pam said. Do a little bit of Netflix therapy. It's always good. I recommend animals too. Animals are good.
Thank you. Kendra, how about for you?
Yeah, great question, Laura. I appreciate that. So we are a pretty active family. So during the summer, I was out on the golf course a lot by myself, which was awesome. Now it's cold and rainy and I'm not golfing. So I've been watching a lot of football. We didn't have TV before the pandemic, but we ran out of activities. So definitely on Netflix and watching football a lot. But my self-care also is trying to put away the news, sometimes to national, local news, and just take a time out from it. So sometimes even that I count as a win for that day for self-care, that I wasn't engorged in all of that. So
Absolutely. Things change these days. Well, yeah, go for it, Michaela.
So sorry, I don't want to interrupt because I know we're not supposed to interrupt during these panels, but I have such a question geared towards this. Is like, I've been noticing that there's days when I just can't see a client and I'm really feeling like things are getting to me. I'm stressed out and I'm going to have to cancel on a client. And then that anxiety and that, feeling like I'm lack of a professional is getting to me. Do you ever feel like that? Is that something that you have ever had to do? And kind of how do you deal with that now, in terms of like, wonder if there's one week where you couldn't self-care and then it kind of got to you and then you kind of fell off, and then how did you kind of deal with that? I don't know. I mean, I think that's kind of where I'm at sometimes. And so kind of want to hear it from all three of you.
Absolutely. Those moments when it's just a little too much. Pam, can you speak to that at all?
I think sometimes taking a sick day includes a mental health sick day, right? I think it's okay to give ourselves a pass, and then we get right back into it, right? If I'm out of the office, can I reserve the right to protect the reason? I'm very transparent, sometimes maybe too much so, in sharing. But if I need like a down day and it happens to fall on a weekday, my question is always, am I going to be useful in serving my client, right? Because if I'm not, then that ethically is not cool. All right. And for me, I always know I will be, if I'm capable, right, I'll be glad to have, once the session starts, like, I'm glad I'm there and I'm glad I'm there for the client, right? I think anxiety and having that up and down, especially as a new therapist, happens a lot. Self-doubt creeps in, right? And so sometimes, discipline begets discipline. I still feel new, right? 3 years. Paddling towards licensure hours and all of those things. And so, yeah, I think it's, at what point is it avoidance, right? And then if it's avoidance, you have a whole nother thing to look at, which is, am I in the right profession, right? So, but yeah, absolutely. I think that's, I want to validate that. Absolutely.
Oh, I was just gonna say, I've talked a lot about how we're using a lot of technology to communicate, and that includes, the cell phone, the computer, and email, and all that. Maybe I would say maybe during non-pandemic, it might be easier to focus on just like meeting during sessions or appointments, and it's a little bit easier to have boundaries. But with the increase of technology, just that uptick, like, I have clients calling me at 5 o'clock in the morning, just like, how do you deal with that? How do you deal with that ethically? And so just, reassessing one's boundaries, like Pam said, like knowing oneself when you're getting to the point where maybe you're not in the best state of mind to, be able to communicate with the clients effectively. Like it's always okay to set those boundaries, and but at the same time, it's with this whole technology thing, I've found that I've had to reevaluate. Do I use my cell phone? Am I going to continue to use email? So I'm just kind of constantly reevaluating it, so hopefully it doesn't get to the point where, maybe one day I'm really overwhelmed and I say something I don't want to say. So, but it's an everyday thing for sure. So I just recommend not waiting till the last minute.
And this is Kendra. Pam and Shannon kind of spoke to it all. If you don't feel like you're going to be your best person for your client that day, maybe it's time to take a day off. And in my experience in social services, most of your supervisors will be completely understanding about that, right? Because they want to give you those breaks. They want you to take time for yourself and self-care, because they want you to be the best person that you can be for every single one of your client every single day. And we as practitioners deal with a lot of heavy things with clients, that we have to, try to, as Shannon spoke to, try to leave it at the door before we get home, so we don't dump it on our significant other or our kids or anything like that, and especially now with the pandemic, like, Shannon spoke to, we're constantly on technology, right? I can be reached 24/7, and I left a congressional office thinking that I would be done with that. But that was not the case. And like I said, once again, like just openly communicate with your supervisors about how you're doing, and and if something's heavy, go and bring it into supervision and be able to talk through that, because you shouldn't have to like deal with that by yourself, because you have all of this support around you. Like I said, especially since all of us have been through it, all of us have been that boots on the ground too, dealing with some pretty heavy client issues and thinking that if we, it's going to be the end of the world if we don't help this client, right now. But it's just so incredibly important to take time for yourself. And I know that does sound selfish, but you have to be the best person you can be for every single client, and be as consistent as possible. So So thanks for the question. Great question.
Any other questions floating around out there?
I do see in the chat, let's see, where am I? Have you been seeing more relapse since the pandemic? It's interesting. I was just talking about this with a colleague, and we think so, but we can't really, it's anecdotal. And we also see cycles of that as well. I work in the mental health piece, not the, drug and alcohol piece. So I'm less aware than those counselors are. They tend to find out like who has completed treatment and relapsed. Like they tend to find out fairly fast. Some of those clients are in outpatient groups. And there's a lot of support. So obviously that's a whole nother area where the pandemic is affecting people's recovery because they are still isolated and doing groups through telehealth and rather than in person. And that, as engaging as this group is, right? Do we want to do that for several hours every day? So difficult. I don't know how you make friends in a group when you don't see each other. So these are things that we think about, and I'm not tasked, with trying to fix that. These are national concerns, I'm sure. Also, when you're talking about like new ways to advocate, are we able to provide other mental health supportive groups, within our community? Maybe it's facilitated by someone where people could just show up in and out and meet people, that, it's difficult to raise our hand and say, hey, I'm here for the depression group, but, like we need to be thinking outside the box.
Absolutely. I love that. There's never just two options. There's always another way. Wonderful. So any other questions out there, or any comments or kind of final thoughts, or even from Pam, Shannon, Kendra, for that's come up for you in the course of this discussion?
I'm curious if over the course of the next week or so, if we have questions that come up after we have time to really reflect about what we talked about, is it okay to send an email and ask a question?
I'm nodding yes, but this is Kendra. Yeah, so I always welcome, questions, comments, or concerns or anything like that. That's how we've gotten interns too. So people being curious about our services and things like that. So I supervise 2 interns, and we always welcome more. So yeah, definitely open to questions.
I love that question, Tiffany. Thank you. Kendra, so you work for the Aging Disability Resource Center. Okay, so you're accepting interns. And I also wanted to ask Pam and Shannon if you actually are accepting interns, because as you may know, our next cohort is going into internship. And we just want to know all the resources that we have. Having your names, having contacts would be really, really beneficial for all of us.
So I will also, if there are follow-up questions, of course, feel free to email me. Willamette family has an intern. She also works part-time as a paid staff member. And so that's really all we're able to staff and supervise. But, therapists know therapists. So sometimes you just have to keep asking, hey, who else can I talk to? Yeah.
I'd be happy to put together a little resource sheet with phone numbers and email addresses and contacts for anybody who wants to follow up. I can email it to the folks that organize this if they want to, just to make that.
Yes, please. Actually, Shannon, that would be great. Thank you.
Yeah, that would be great, Shannon. Also, I wanted to ask you just one more question about working for the VA. So I know it's very beneficial for you to have a background in veteran affairs, but is that something that can possibly hinder you into getting a job there or an internship there if you don't have necessarily that background? Or yeah.
Not necessarily.
Okay.
One of the best clinicians that I work with worked for state hospital in Austin, Texas beforehand, and didn't have a whole lot of experience, and she's great. So I think it really depends on what you're bringing to the table when you get hired. It doesn't necessarily have to be with veterans, because, like, you know, for example, I work with mostly with folks with severe and persistent mental illness. So, you know, having the vet's cultural competency does help, and like having been a congressional aide for 6 years and knowing all the policy and all that stuff, it helps, sure, but will it help with someone who's like in acute psychosis? I don't know. So you kind of got to weigh those things. So,
Yeah.
but certainly, you know, getting some experience interning and somewhere around that, like I mentioned before, I worked with Sonia at the Eugene mission, and that did help. But I wasn't hired there specifically to help veterans. I was hired to help with folks experiencing severe mental illness, and I just happened to come across many veterans along the way. So you might be surprised in where you'll pick up certain experience, and you know, whether you're working with senior and disability services, you know, they work with a lot of veterans and have their own vet specialists, and Land and Family works with a lot of veterans. So there's, like Kendra said before, there's a ton of intersectionality where you'll pick up that experience. So yeah, hope that helps.
I wanted to add something that it's related, right? It's tangential. One thing that I wish somebody would have told me as a master's student is that mental health is a business, you know, at the end of the day. So we get in it to serve other people, and we have to document, and we have to pay insurance, and we have to do the freaking paperwork and get authorizations, right? And that's not what I care about. So I just really wish somebody would have prepared me for the reality, right? I'm not saying I would have done anything differently. It's just I was surprised that being a good therapist is only part of the work. So.
Yeah, and this is Kendra, Pam. That's a good point, because I am on that side of things when it comes to billing and the money portion of things, and how important documentation and data actually is, because that is how we get funding. So all of that stuff that you never thought you would do is probably going to be part of your job when it comes to, you know, tracking certain things and outcomes and things like that at these agencies as well. When I was a master's of social work student, I thought I would do youth mental health, and now I'm a data analyst. So it's just so funny how, you know, we start on one path, and then, you know, we get these experiences and these internships and these practicum placements and things like that, and then we end up somewhere that we never thought we would. But to Pam's point, the data and things like that you don't think are important is how, you know, how folks get funding and stuff like that. And Pam hit the nail on the head. You know, you didn't think this was a business, but billing insurance and all that stuff is a large part of the money trail. So.
See, Shannon, you are nodding very emphatically over there.
yeah, documentation and filling out forms is at least half of what I do. So, and while I'm doing more with casework than just individual hour-long psychotherapy sessions, I guess that's a good example of you can use your degree in a lot of different ways. A lot of folks do want to stick to that hour-long psychotherapy session, but there's so many different diverse ways to work in the mental health field. But I totally agree. Knowing how to fill out a government form or an insurance form certainly helps. So anywhere you can get experience of that will be beneficial.
Excellent. Really appreciate that, because again, I'm in the gap right now, right? I just graduated, and until I get my registered internship, I can do nothing. So I'm pretty sure I was told that at one point, but it sure didn't click right up until Friday. So it's very interesting how this field, there's a lot of I's to dot and T's to cross. And I really appreciate the insights that all three of you have brought in today, in particular with these populations that are struggling. I mean, they have been struggling, and they're struggling even more now, considering the current, again, I love that, this COVID culture. And your willingness to come in and again, give of your evening means, it says so very much about your character and your professional excellence and your own, your personal humility and ability to come out and speak for your people and for yourselves. So on behalf of CSI, on behalf of our listeners, whom I know our listeners, this is not a podcast, the people who will watch this later, thank you so very much for joining us this evening. If there's any final thoughts or comments, please feel free.
No, I just wanted to thank you for the opportunity. It's wonderful to see, the fresh intellectual interest, right, and the passion. It's 8:27 and for you guys too, right? So, and when you are asked at some point in the future, you will also say yes, right? Pay it forward, all those things. Yeah.
Absolutely. Thank you, Pam.
I was going to say it's great to reconnect with our local counselor community, and you guys, I'm sure you've been involved in the community all along, but it's great to see folks coming into the field and meet some of y'all. So exciting.
Absolutely. Re-up your membership, Shannon. Come on, come back. Thank you for coming this evening. Greatly appreciated.
Yeah, and this is Kendra. And once again, thank you all for the invite. We really appreciate being able to come and talk to y'all, because not that long ago, 2 years ago, I was in that seat, trying to figure out what I'm going to do. I want to talk to everybody, trying to figure it all out, and you don't have to have it all figured out. It's the ebb and flow of life, and you just got to go with the flow, and you'll end up in places that you never thought you would end up. So it's a wild ride. So hang on, y'all.
I recently was told by my clinical supervisor, who does not work for my agency, that the average is 3 experiments in work, right? Until we really land somewhere that we feel, okay, maybe I can be here for a bit, which I do find comforting, because sometimes I feel behind, right? What am I behind on? Right? Okay, so you didn't get signed up for your internship, right? You will. Right? You will. So,
yep.
Yeah. So I'm kind of glad to know, hey, if if things don't stick the first time, like I'm just still in the average.
Absolutely. That's
Yeah.
well spoken, Pam. And Kendra, thank you also for coming here tonight and speaking on behalf of an incredibly underserved population. They have quite the champion in you. Right.
Thank you. And if anyone has any contact with Doyle Schrader, tell him I said hello.
Absolutely. Will do. Right. Thank you again.
Yeah, and I do just want to make one final comment. Thank you to all of our presenters, but also this is our December monthly series panel, and a panel of series every month on the third Thursday of every single month. The third week, not the third of the month. And so next January, in January 2021, we will be bringing you a crisis and de-escalation training from Kimber, who is actually in our cohort. And that'll be on the 21st at 7 p.m. So for all the people watching, for all the people here, I hope you tune into that. And it's in a long line of very exciting upcoming free panels for CSI members.
Thank you very much, Michaela. All right. If I could get my team to stick on, but everyone else, thank you again for attending today. I'm going to go ahead and stop the recording.